So today I will be talking about RRT prescriptions, mostly regarding this acute hemodialysis prescription. So the goals of RRT in acute kidney injury are to achieve or maintain fluid balance, electrolyte balance, acid base and solute homeostasis, or prevent and minimize worsening of AKI or uremic, permit renal recovery, and facilitate fluid allowances for attrition, for nutrition, medication, obligatory fluid intake. There are some absolute indications for acute hemodialysis prescription. There are some absolute indications for the hemodialysis, that is refractory hyperkalemia, refractory acidemia, or acidosis, refractory pulmonary edema due to fluid overload, then symptomatic or complications attributed to uremia, like encephalopathy. And the fifth one is overdose or toxicity from the dialysis or drug or any toxins. When prescribing hemodialysis in the acute hemodialysis, the elements are session of the length, blood flow rate, dialyzer, then dialysate composition, dialysate flow rate, dialysate temperature, then ultrafiltration orders, and anticoagulation. Within these, session of dialysis length and blood flow rate are the most important determinants for the removing the dialysis, for the removal of the dialysable fluid. So the hemodialysis session length and blood flow rate. Most important determinant, the session length and the blood flow rate are the most important determinant of the amount of dialysis. Generally, this initial dialysis sessions for the initial 1 or 2 sessions, especially when pre-dialysis serum urea nitrogen is more than 125 mg per deciliter, both dialysis session length and blood flow rate should be reduced. Here, we should target urea reduction ratio less than 40%. All these terms we have learned in the last session. So, sorry. We are just going through it. So for the initial 1 or 2 sessions, this target of urea reduction ratio should be less than 40%. And generally, the blood flow for the dialysis is generally a standard measure is 200 ml per minute for adults, and for the smaller patients, it is 150 ml per minute for small patients. Generally, the initial dialysis should be done for the 2-hour length sessions using low efficiency filter. To prevent disequilibrium syndrome, we should aim for the urea clearance of 30% for the first treatment. That is KT by V is around 0.7. Then 50% of the urea clearance for the second treatment, which equivalents to KT by V of 1, and 70% or more for the third or subsequent treatments. That comes as a KT by V as 1:2. For initial blood urea nitrogen less than, can I close this down? I will do. Sorry, for initial blood urea nitrogen less than 100 mg per deciliter, we'll aim for the urea clearance of 50% for the first treatment and 70% for the second and subsequent treatments. In generally second hemodialysis, the duration can be increased to 3 hours when pre-dialysis serum urea nitrogen is less than 100 mg per deciliter. Length of the single dialysis treatment rarely exceeds 6 hours unless dialysis is for the drug overdose in acute hemodialysis. a typical 3 to 4 hour acute dialysis session will deliver KT by V of only 0.9 with equilibrated KT by V of 0.7. Generally, equilibrated KT by V is 0.15 lesser than the SPKTV by V. This low level of KT by V, if given thrice a week, is associated with high mortality in chronic stable patients. The option for this is to dialyze the sick patients of acute kidney injury on a daily basis, that is 6 times a week, with each session length of 3 to 4 hours. In this way, the mortality can be reduced as described in Shifal study in 2002. Then a VANH study in 2008 compared the outcomes in acute patients which dialyzed either 3 or 6 times per week. In this study, the intensity in thrice a week group was substantially higher, that is KT by V of 1.3 or more than in the Shifal article. For this reason, the KIDGO work group on AKI 2012 recommends KT by V of 1.3 or more for each hemodialysis session for acute patients on thrice a week hemodialysis. So we can verify the hemodialysis adequacy by urea reduction ratio, which can be measured by blood test, ionic conductance, and UV absorption technologies. Then choosing a dialyzer. In choosing the dialyzer, the membrane material, which is not studied as a separate factor. Then ultrafiltration coefficient, use of dialyzers of high water permeability, that is coefficient more than 0.6 is recommended. Dialyzer urea clearance, that is K0A. For first couple of hemodialysis sessions, we should avoid using very high efficiency dialyzers. A dialyzer with urea clearance of 500 to 600 ml per minute is recommended.
Why that so? Why you don't want to use very high efficiency?
Because with the high efficiency dialyzers, we can over dialyze the patient, and which can lead to a disequilibrium.
So you don't want very rapid movement of solids,
and instability in the patient.
And what is the dialyzer? You said material. You have not gone through.
Yes. So the dialyzer material, the membrane material. So there has been some in the Cochrane review report, they have suggested there are no firm conclusions that could be drawn on the benefits of any one group of modern dialysis membranes over another for the acute or chronic dialysis. The best dialyzer to select for acute dialysis remains unclear. There are no recommendations.
I would ask Bhaparupa, any comment on the dialyzer material?
Yeah, so the dialyzers that we use nowadays, if you go by Fresenius, all of these are non-cellulose synthetic material. So cellulose-based dialyzers were used way long back, but they were associated with a lot of dialyzer reactions. So nowadays, all dialyzers that we use are very much biocompatible. Dialyzer reactions are very rarely seen nowadays, and all of these are non-cellulose and synthetic materials. Some polyacryl nitrile or PMMA, these are the dialyzer materials that are commonly used nowadays.
Hello.
Hello. Yes, sir.
Hello.
Yes, sir.
See, PMMA is polymethyl methacrylate, which is a dialyzer membrane without too much of reactions. Okay. However, the one that you other mentioned, polyacryl nitrile, that's the tough one, because that in case of ACE inhibitors can have a bradykinin reaction.
Yes,
okay,
yes.
so the
Correct, sir. Yes,
AN69 membranes of the past or polyacryl nitrile for present. So this was initially actually shown with the AN69 membranes. But now with the polyacryl nitrile is one of the most difficult to use, because particularly if you are on ACE inhibitors, you can have an issue. But most of us use the the F6 or the F8 that we commonly use are all
Hmm.
PMMA membranes, and they are quite bio-friendly, and they don't cause much reactions. That being said, dialyzer reactions, both type 1 and type 2, are still seen in practice, and we need to know them, because if there is a dialysis reaction, we think that our membranes are compatible and there can't be a reaction, we will not diagnose them. So I'm sure you know of the type 1 and type 2 reactions of dialyzer, right?
Hello?
Yeah, you are
Hello?
aware
Yes,
about the
sir.
type 1 and type 2
Yes, sir.
reactions, right?
Yes,
Okay,
sir. Yes,
fine.
sir.
Okay, continue.
So, the ultrafiltration coefficient, while choosing the dialyzers, we use dialyzer of high water permeability, that is KUF coefficient of more than 6. Then dialyzer urea clearance. For the first couple of hemodialysis sessions, we should avoid using very high efficiency dialyzers. And dialyzer with the efficiency of 500 to 600 ml per minute is recommended. After initial 1 to 2 sessions, particularly when high blood flow is being used, normal size dialyzer can be used. The dialysis solution normally consists of a base bicarb of 25 millimole, sodium of 144 millimole, potassium 3.5 millimole, calcium of 1.5 millimole, then magnesium of 0.375 millimole, dextrose of 100 mg per deciliter, and there's no phosphorus. And this dialysis solution can be altered as per the required as per the patient's requirement and particular circumstances. So for the metabolic acidosis, the bicarb we should target of around 28 or more in the dialysate blood. Metabolic alkalosis or any kind of alkalosis is harmful for the patient's homeostasis. Dialysis we'll see in particular dialysis solution in the dialysis solution sodium levels. If this hyponatremia, that is hemodialysis sodium is more than 130 millimole per liter, then we should do dialysate sodium of 140 plus, that is pre hemodialysis sodium 140 minus pre hemodialysis sodium, and whatever the value it comes, we should achieve the dialysis solution sodium level around that. And if the pre-hemodialysis sodium is less than 130 millimole, then dialysate sodium level of 15 to 20 millimole above plasma level we should target. In the hypernatremia, the safest approach is first dialysis with the dialysate sodium level close to that of the plasma. And simultaneously, we can slow administration. We can do slow administration of slightly hyponatremic fluids to achieve the normal sodium. But this should be very slow and not to correct too rapidly for the hypernatremia.
Shatarupa and Rushi sir, I have a question on this, that how do we manipulate the level of sodium in a dialyzer? Particularly, this is a very practical question. Last time we were trying to keep the sodium level at 145. So I was struggling, and one of the technicians told me, why don't you give sodium separately, directly in the circulation rather than manipulating through this? It is difficult to increase or decrease the sodium level.
Okay. Rushi sir, do you want to have a take at this?
No, you go ahead. Go ahead.
Okay. Okay, so if you're dealing with a case of hyponatremia, then again we will have to categorize hyponatremia as mild, moderate, and severe. So mild hyponatremia is still 130. If the sodium is 130, our dialysis sodium is approximately plus 138 onwards, then it's not of a problem. The problem occurs in moderate and much more in severe hyponatremia. So the lowest sodium that our conventional dialysis machines have can allow without running conductive errors is around 129 to 130 in almost all the machines. So if a patient has a severe hyponatremia, which is less than 120, then we have to keep the lowest value, which is 129 to 130. And we have to check after dialysis if the sodium has got overcorrected. If it has got overcorrected,
Hello. Hello.
for hypernatremia, you have to see if you can correct the hypernatremia without changing the sodium of the dialysate. If the patient is grossly dehydrated, if that is the cause, then you might calculate the free water correction and give it apart without like separately or by a separate port. And also the thinking the logic is also similar over here, that the sodium correction post dialysis should not go more than 6 to 8 MEQ from the pre-dialysis sodium, and the highest possible sodium that is tolerable for machines is around 145, if I'm not mistaken, for most dialysis machines. So that is on a that is a bird's eye view of how we manage sodium in dialysis. Apart from that, again, obviously the cause has to be determined. Sodium, hyponatremia are mostly water disbalance. So you will have to match the intake output and finding the cause. And if it's an ADH related mechanism, the treatment will be separately decided again. So these are the multiple causes. It is very difficult to pinpoint and give one particular answer because it varies a lot from one case to the other. So Rushi sir, will you add something? Hello? Hello?
I think it's fine. We got it. Then we'll take the question later on. So you carry on.
Okay. Then dialysate potassium
So
levels.
one second, ma'am.
Yes.
So if we can have maximum of 145 of sodium in dialysate, and if the patient is having say sodium levels of around 180, we have one patient whose sodium was around 180, and if he goes into dialysis, so will it be okay that we can dialyze with the dialysate sodium of 145 with this patient
Yes,
who
so
will
you
have a
have to
rapid
dialyze. So if
correction
you have so if you have
with
a
this
patient
rapid
with a
correction? Can
sodium
happen?
of
Yeah.
180, you have to dialyze. And if there's an acute indication of dialysis, then you have to dialyze it. Dialyze the patient against a sodium of 145 only. But then you will have to check your sodium after 1 hour, after 2 hours, after 3 hours of dialysis and check the levels. It is very difficult to predict exactly. It's not like you're dialyzing with a sodium of 145, a patient of 180, so the sodium will not stay. You cannot predict that the sodium will stay somewhere between around 160. You cannot predict that also. So the sodium levels have to be checked every hour on dialysis, and if there is rapid overcorrection, if the patient has got a like you have to target 170, 172. If there is further fall, like if the patient has got a sodium of 160, then you will have to build that up again with 3% NaCl. But yes, if the patient has got an acute indication for dialysis, you will have to dialyze with this kind of sodium only.
So other than monitoring, we don't have any. We can't manage that
No.
with that gap.
So no, that
Yeah.
for
Okay.
that,
Okay.
for you have
Okay.
to manage the cause, find out the cause of hypernatremia, which will be different for different cases, and tackle the cause.
See, I would
Okay.
personally want to avoid dialysis in this situation. And
Yes,
you
yes.
should really try and see what is the indication. Why do you want to dialyze against such a huge sodium difference? Because unless your indication is such that it is unavoidable, I would not wish to dialyze this patient. Because a rapid shift in sodium, we all know what can go wrong, right? So
Yes,
it is better to avoid dialysis
it is
as
100%.
much
If
as
it's
possible.
avoidable, yes.
As much as possible, we should avoid. Because if the sodium
Yes.
can go to 180, this patient has intravascular volume contraction of how much? Just
Yes.
imagine. I mean, if I was to just calculate a rough number at a weight of 70, we are talking about a volume contraction of how much is that? 40 to
Sir, mostly
Or
180 of sodium, typically we
yeah,
see into where your brain dysfunction is quite prominent, or cerebral
no, I
edema
mean, see,
already.
this, for that kind of a thing to happen, you need to have a DI which is just not corrected. And the kind of water
Yeah,
deficit that you need in a patient
yes, sir.
will be to the tunes of 20-30% of their body weight.
Yes, sir. And the
Just to
second thing,
get this
sir,
kind of sodium.
I think so. In this cases, anyways, with the kind of sodium you have cerebral edema, and the preferred mode of dialysis is usually CRRT, where you can actually have you actually can have monitored way of giving and how much of dialysate, how much of an replacement. Whether that will benefit, because slow dialysis for 24-48 hours and a gradual correction can happen. Is that possibility with
Yes.
that?
Yes, CRT is obviously the first preference. If you have to dialyze, then CRT is obviously the first preference in any case where there is a brain edema which comes into the picture, and then CRT is obviously the first choice.
I guess with 180 of sodium, possibility of an cerebral edema is very high. And then going ahead with CRRT and trying to gradually see or monitor the sodium, that's the way forward. I'm unsure about doing a sled in this situation, but definitely CRRT may help. So Hemraj, I think so. Your question is 180 to 145 equilibrium. I guess we can start with CRRT and monitor how fast it is getting corrected, and according to that, we need to take a call how much amount of fluids or how much amount of things we can replace or do something about it. And in this situation, I think so. Usually, you use vasopressin as well, which will also help into your corrective measures and everything else. So may not be an correct answer, but yes, possibility of nearby. I think so.
Yeah. Okay, sir.
Can I go ahead, ma'am?
Yes, please go ahead.
So dialysate potassium levels. Usual dialysate potassium concentration for the dialysis is 2 to 4 millimole. If the pre-dialysis serum potassium is less than 4 millimole per liter, then dialysate potassium we can target around 4 millimole. If the pre-dialysis serum potassium is more than 5.5 millimole per liter, that is hyperkalemia, then if for the stable patients, we can use dialysate potassium of around 2 millimole. And for the risk, if the patient is at risk of arrhythmia, then we should use a little bit higher, like 2.5 to 3 millimole of potassium in the dialysate fluid. Pre-dialysis, if the pre-dialysis serum is more than 7 millimole per liter, then dialysis of potassium should be targeted less than 2 millimole, and we should monitor plasma potassium hourly. There will be potassium rebound in the system after the dialysis, which will cause increase in the serum potassium, which is seen within 1 to 2 hours after the hemodialysis. That's why we should not treat post-dialysis hypokalemia with potassium supplements. Dialysate calcium levels.
Okay. Sheetal, can I just say one thing? So
Yes, ma'am.
while adjusting the pre-dialysis potassium, there is one thing which we known as, which is called as rule of 7. So that is something that we broadly follow. What is this rule of 7? It is the pre-dialysis potassium plus the dialysate potassium should be equal to 7. So for
Okay.
example, if you have a patient whose pre-dialysis potassium is 6, then you will mostly choose a dialysate with a potassium concentration of 1. Okay, so that is one rule of thumb that we follow for this for choosing our for dialysate potassium. The
Okay,
other
ma'am.
thing that I would like to highlight in this hyperkalemia pre-dialysis is that we generally get a lot of patients who come with uremia, hyperkalemia, and there is a tendency to give this glucose insulin. Obviously, you have to give it, but one thing we have to be aware of is this: on this treatment for hyperkalemia, this IV GI drip that we give, this push the potassium inside the cells. And what happens is that when you start dialyzing, this potassium which has gone into the cells, this intracellular potassium is not available for dialysis because it is inside the cells. So if you're planning a dialysis for such a hyperkalemic patient, then try to avoid insulin and glucose in the few hours prior to dialysis, starting of dialysis. Okay, you can carry on.
Okay, ma'am. Okay. Dialysate calcium levels. The normal level for the hemodialysis are 1.25 to 1.75 millimole, that is 3 to 3.5 milliequivalent per liter. The dialysis solution calcium less than 1.5 millimole, that is 3 milliequivalent per liter in AKI. This predisposes may predispose to hypotension during hemodialysis. The pre-dialysis hypocalcemia, if it is there, then we can use dialysis solution calcium of 2.5 milliequivalent per liter. The dialytic treatment of acute hypercalcemia. The dialysate calcium we can use to 1.25 to 1.7 millimole, that is 2.5 to 3.5 milliequivalent per liter. We should do frequent measurement of serum ionized calcium and physical examinations to avoid the complications. Dialysate magnesium levels. Usual dialysate magnesium levels are 0.25 to 0.75 millimole, that is 0.5 to 1.5 milliequivalent per liter. This BP control in the acute magnesium, dialysate magnesium of 0.7.5 milliequivalent per liter is better than the 1.5 milliequivalent per liter in view of BP control in the acute dialysis, as magnesium is a potent vasodilator. The best dialysate magnesium for acute dialysis in terms of blood pressure control is not known. Then dialysate dextrose level. We should target the dialysate dextrose level around 100 to 200 mg per deciliter, that is 5.5 to 11 millimole per liter. Dialysate flow rate. It is usually 500 ml per minute. That is, it is twice the upper limit of blood flow. Beyond this, this gain in the solid remole is minimal. So maximal dialysate flow rate will be 500 ml per minute. Then dialysate temperature. We usually target 35 to 37 degrees Celsius of the temperature. Lower range should be used in hypotension or hemodynamically unstable patients. Then ultrafiltration orders. Fluid removal rate of 10 ml per kg per hour is usually well tolerated by most of the fluid overloaded patients. This ultrafiltration should be done at constant rate, and we should avoid hypotension at all times, including during the dialysis. That's all about acute hemodialysis prescription, ma'am.
Now, Swaturupa, anything else on other?
Yeah, I would just like to. I would just like to highlight one point regarding the duration of dialysis. So now acute hemodialysis, the continuous varieties, if you're using the continuous varieties, that will be obviously a 24-hour long and a continuous procedure. There is a prolonged intermittent dialysis also, the SLED forms that we were discussing the last day. So the SLED forms, the duration of the SLED forms is minimum 6 hours to 12 hours. So that is one. I would like to highlight that one. I think somewhere you mentioned that the duration should not be more than 6 hours. So yes, if you're doing a SLED dialysis, then you can obviously, for the first instance, from the first time only, you can go anywhere between 6 to 12 hours without the risk of dialysis syndrome. And the length of any normal SLED session is minimum 6 hours. Okay, the length is to be decided based on the other parameters. Okay, and yeah, so hypotension is one of the most common complications of acute hemodialysis. The patient obviously are not so stable enough. So how will you manage hypotension? At least let's discuss one complication of acute hemodialysis.
Now, Shatarupa, I purposefully
Okay, sure.
left it out because we have
Okay,
one
sure.
or couple of sessions for complications separately.
Sure. Okay, then carry on with the rest.
Now,
Yeah, sure.
I think I would ask you one more thing, that
Hmm.
if I say, just for the sake of practicality, that if I have to write a form or something of that sort, that what are the points that should be there in the prescription form? So should it have a access? Because I teach my students like that the therapy, the choice or the mode, whether this is intermittent slate or CRRT, what is my access, what is blood flow, dialysate flow, temperature, then
Yes.
ultrafiltrate, duration, anticoagulation, nutrition, the medications that would be allowed. So can you just give a little bit of elaboration like that?
Yes. So definitely the mode of dialysis that will come as the first one, that what you're prescribing. The dialysis session length
So the
will
first
come
one would be
next.
mode. Okay.
Mode of dialysis, length of
Very good.
dialysis, access
Then
of
it will be the
dialysis.
duration.
Yes, duration of
Then-
dialysis, access that you're using.
Right.
Okay. Then a blood flow rate, dialysis flow rate that you're prescribing. Then it will come the dialysis
So what should be the
temperature.
average in between the blood flow rate?
So it will depend entirely on the modality.
Mode.
If it's a usual hemodialysis, then we start with somewhere then the blood flow should be around 300. If you're
Right.
going for the prolonged intermittent, the blood flow, we generally start at the lower side. Blood flow should be around 180 to 200, and the dialysate flow we keep at 300. This is for the prolonged intermittent or the sled varieties. And the CRTs, we do not have much use of it. We do not have such facilities over here. So, but in general, also 200 is the average flow rate for CRT also. So these are mostly low flow dialysis as well as compared to conventional hemodialysis, where the blood flow is typically kept around 300. And the dialysate flow rate will be approximately 1.5 times to 1.8 times of the blood flow rate. So once these two flow rates are there, then dialysate temperature and then dialysate composition will come. So in acute hemodialysis, you should be ideally prescribing the potassium concentration, the sodium concentration, the bicarb concentration, calcium concentration also, and the glucose concentration. At least these things you should, an ideal acute hemodialysis prescription should have all of these things. Then
Sodium,
it will come
potassium,
the
and bicarbonate.
sodium, potassium, bicarb, and calcium and glucose also. Ideally, you should be at least prescribing these characteristics of the dialysate. Then will come the ultrafiltration. What is your ultrafiltration goal? Sometimes we cannot predict one particular ultrafiltration value for the entire length of hemodialysis sessions, because we have to see how the patient is tolerating the dialysis. So you can prescribe, for example, 100 ml per hour for 2 hours, and then you can come back and see how the patient is tolerating, and then SOS increase. So most of the times,
it should be dynamic. It should be dynamic.
Yeah, exactly. So most of the times we cannot just write that, okay, I want 1 liter or 1.5 liters to be removed. We prescribe per hour, and then we can SOS modify. Then obviously the anticoagulation will come. And if you want some monitoring to be done during the dialysis, obviously the monitoring has to be done of cardioscope monitoring, blood pressure, glucose monitoring has to be done. Apart from that, if you want some particular, for example, if the patient has dysnatremia, dyskalemia, if you want sodium and potassium to be monitored, all this have to come in the entire dialysis prescription as well. Okay, hello.
I have one or two more things. One is, should we include the antibiotics here also? Because if we are doing particularly SLED or CRRT, the dosing has to be adjusted accordingly, right? So
Yes.
And because this is quite important for critical care, so should we have a separate column for antibiotics?
So the textbook teaching, Dr. Rushi will be able to highlight better, but the textbook teaching, if you per se see what textbook highlights. I don't think antibiotic perception curve, but this is mostly not a practically it should come, because that is what we have to tell the sisters and the nurses.
I'm just giving a practical example, Shatorupa.
Yeah, practically
that,
I agree 100%.
if I'm making a prescription on behalf of you, obviously not on behalf, I'm taking guidance from you, but I'm also including my important aspect. So the critical care aspect would be the drug dosing. And the other thing that I always try to include is the nutrition, because there is a lot of nutritional issues while a patient being on dialysis, particularly the protein, calorie, vitamins and minerals. So do you want some you want to give some practical tips on the nutritional prescription?
Vindam, I think Das sir is also there, na?
Sir?
Das sir is attending, I think, कि नहीं?
Yes. I can see Das sir is there.
मेरे यहाँ पे ये मैं शीतल का इससे कर रहा हूँ, यहाँ पे सिर्फ 4 लोग दिखा रहे हैं सर. तो क्या?
नहीं, I can see Das sir, I can see Rushi sir also. So if anyone wants to take this question.
Because he.
Das sir, please.
This is a very practical. हाँ, Das sir होंगे तो Das sir को पूछिए, नहीं तो फिर मैं बात करता हूँ.
दास सर कहाँ पे हो तुम? कुछ नहीं दिखाई दे रहा है यहाँ पे. 4 लोग दिखाई दे रहे हैं.
Arindam, I'm there.
दास सर, please.
हाँ, दास सर आप बात करो फिर, चलो.
अच्छा, routine prescription. What you are talking about, routine prescription including antibiotics and the nutritional. Actually, in our dialysis textbooks, it is not there. If you want to plan it, you can extended versions, you can do it. Only thing you have to take into account in antibiotics, what is the nature of antibiotics, whether it is concentration dependent or it is a time dependent. So if it is a concentration dependent, then please do so. Do a additional dose can be given after the dialysis so that you can achieve the highest concentration what is required. If it is a time dependent, maybe at intervals you have to give the antibiotics. And besides that, there is volume of distribution also. Like you are taking out fluid, so volume of distribution will be different before the dialysis and after the dialysis session. So all these pharmacokinetic studies are there, and it has been already, there are good books available. One of them is basically a small book, which you can, a critical care nephrology or a DNP nephrology can get. That is a handbook of prescribing medication in dialysis population by Aronoff. That gives you in glimpse how you have to plan it. But usually what happens, it is not in the prescription of ours. Since individually you cannot make it a protocol driven. The prescription, what is required is protocol based. That these things are there, so you can do this laid with this protocol. But antibiotics is basically a physician or a intensive care who will be, or the person who is a infection expert, they will be taking into that which antibiotics will be better in that scenario. So obviously that cannot be included in the protocol based analysis.
What I'm trying to say, that I am not asking that which antibiotic. What I am saying, for example, a patient, we have decided to start and initiate, or a patient is ongoing dialysis, and that person is getting 3 antibiotics. So whether while prescribing the dialysis dosage, we also specify that these are the antibiotics which are ongoing. I'm not trying to change that. So what should be the dose of those, particularly not only antibiotics?
Those doses and other things are basically all are pharmacokinetic dependent. So
yes,
that is available in that book also. And there is another what you are commonly following is the Sanford guide. The Sanford guide has the renal dose adjustment with CRRT, with SLADE, with intermittent hemodialysis, how much is the requirement of additional dose, or how much is the dose concentration or time dependent time. Yeah, all those things are there. What
Right,
I
sir.
need to emphasize in one of the highlight the points are basically the calcium, which has been already discussed, that it should be between 1.25 to 1.75. By default, it is 1.75 millimoles per liter. So by default, but there are certain instances where you have to reduce the calcium level, that is to 1.25. That is in hypercalcemia related, where you want the calcium to be removed.
Right.
However, the question about increasing the dialysate calcium, I asked this question to one of the expert in the dialysis, basically in Toronto once, that whether like the sodium profiling you do for hypertension, for hypotension, you can actually do calcium profiling as well. But what is the problem? Problem is basically increasing the level of calcium in your blood. And that calcium can bind with the phosphate and can get deposited in the vital organs, intrinsic organs of your body, that too increases the calciphylaxis. What is calciphylaxis? Calciphylaxis is deposition of calcium and phosphate products inside the arteries and veins of the that will obviously compromise the luminal blood flow. So that is a bad consequence of doing dialysis with a higher calcium level. Usually it is not practiced. So that we can take it out. So by default, we should keep that the calcium level should be 1.75. And in case of hypercalcemia, you can reduce it to 1.25. And the dialysate flow wise, the machine has only three values. One is 300 ml per minute, one is 500 ml per minute, and the another one is 800 ml per minute. So sometimes we use 800 ml per minute to increase the solute clearance. But the question about how resourceful it will be, whether it will be beneficial for the patient by increasing the solute clearance against the cost of therapy. Obviously, the cost of therapy will increase since the dilated jet consumption will increase. But the fraction of solute clearance which will be required for that will be very marginal improvement, you can say. So that's why Satrupa told that 500 ml is good enough. 500 ml per minute. But the machine, if we use, it has three parameters. That is 300, 500, and 800 ml per minute. Rushi, any points to be from your side?
Nice, Sudhir. I think most of them are covered now. I think let's keep it a little simple so that everybody can take home some take-home points at the end of the discussion. Because I think a lot of the audience is non-nephrology, and so they need very practical take-home points that will be simple for them to use on a day-to-day basis when they are doing dialysis in the ICU. Let's keep that in mind and then keep our discussion at that level more. That's what I feel.
Okay.
So request both to you and Satrupa to keep it very practical for the student, because most of our audience is actually ICU doctors who are trying to do nephrology in their setup, correct?
Yes.
Thanks.
Das sir, one more thing is that if it had been, we are prescribing for CRRT. So what would be the additional points in the prescription?
CRRT. So CRRT, basically, we have to decide ahead of time whether we want to do hemodiafiltration versus hemodialysis or hemofiltration alone. By default, according to the CRRT people, those who are managing this, means manufacturing this, they have the opinion that, sir, please, in the initial period, you keep the modality as hemodiafiltration. Since it is better to convert from hemodiafiltration to hemofiltration or hemodialysis, it will basically, it will be a seamless way. Whereas if you want to have from hemodialysis or hemodialysis to hemodiafiltration, it is a little bit, again, the resetting has to be done for the dialysis machine, the CRRT machine, sorry. So that's why the initial period we should aim at, probably, means it is, if somebody is, you see that there is no way we should be utilizing dialysis rather than hemofiltration will be much more better. So in that scenario, you can start with hemofiltration. But if we are unsure that what modality will benefit the patient, then go for hemodiafiltration.
Okay. So modality is hemodiafiltration, and regarding the
Then comes the what is the volume you want to give, dose of hemodialysis. The dose of hemodialysis is basically is calculated roughly with the ideal body weight around 25 to 30 ml per kg. Yeah. 25 to 30 ml. Sometimes we go overboard, we can maximize to 40 ml per kg per hour. But that too, beyond that, actually, it doesn't help. Beyond that, it doesn't help. Unless until you want to have a high volume of clearance, in the sense that if there is a toxin buildup, let us say that if it is a phenobarbiturate poisoning or any poisoning which is dialysable, or we can take it out by hemofiltration. So in that scenario, we can use higher doses.
We will discuss this different modalities for different day in a separate class, sir. Let us first come one by one on the prescription topics. Yeah.
Then the blood flow, how much you want to keep it. The blood flow is basically, you can keep it between 100 ml to 150 ml, or maximum you can go up to 200 ml per minute.
Yes,
sorry, per minute.
Yes.
Then comes the pre-bump PBP, that is pre-blood pump PBP. Then post-filter, how much is the volume you want to give, and dialysate flow.
So then comes the replacement fluid, right? So pre-filter and post-filter.
Pre-filter, post-filter, and dialysate if you are doing hemodiafiltration.
Yes,
so
sir.
On an average, it is divided into 50%, 50%. So you give dialysate 50% in hemodiafiltration and 50% hemofiltration, that is pre-PBP and the post-filter. Then if it is a, let us say that if it is a heparin-free dialysis.
Sir, 1 minute. Can you please clear that overall 50% in terms of ml? I think the students didn't get it clearly.
No, it is basically, you have to calculate, let us say that it is 30 ml per kg.
Okay, sir.
So let us say that you are total dose we want to deliver is 2000 ml.
Okay, sir.
Okay. So 2000 ml ko you can divide into 1000, give 1000 ml per hour of dialysate, and give 1000 ml of post-filter and pre-filter. So pre-filter usually we give 20% and post-filter we give 80%. That is the normal prescription. So you can give 200 ml in the pre-filter and you can give 800 ml
20% of the total, 20% of the total doses is 20% of the 50%.
Of replacement fluid, sir.
Replacement fluid, you one is 50% will go to the dialyzer. 1,000 you have given.
Right.
And out of
1,000.
another 1,000.
20% of that 1,000, whatever is remaining. Right.
Yes.
Okay.
Then comes whether you want to give the dialysis if it is a heparin free, then sometimes what you can do, you can increase the pre-filter replacement fluid so that the flow inside the dialyzer capillaries will be more so that the clotting chances will be less. So accordingly, you have to reduce the post filter. But hemofiltration it is better to give a post filter, since when you give pre-filter a high dose, then it causes more concentration of blood inside the dialyzer, and it can get clotted. So that is, I'm talking about the prescription now. So pre-filter, post-filter, and dialyzer. Okay. Then you choose whatever your anticoagulation is. Then, hello, Arindam, can you hear me?
Yes, sir.
Yes, sir, we can hear.
Yes. Then you have to decide about ultrafiltration. So how much ultrafiltration you want to take out. So it will be obviously in hours. Sometimes what happens, if you try to take out more, then the intravascular blood volume, effective arterial blood volume will go down, and it will cause hypotension, further hypotension. So you have to basically judge. That is how it has to be, that it is dynamic situation. So you initially start with 50 to 100 ml, or you can start with only 25 ml per hour, then increase that according to the blood pressure and monitor the blood pressure and see the inotropes, how much is it. Then comes the filtration fraction. The filtration fraction is calculated by the machine itself, looking into the pre-filter, dialysate, and the an idea about whether the filter is how much efficiency it is running, whether it is going to get clotted. So on an average, we want to keep the filtration fraction less than 25%. That happens only in Baxter, that is Prismaflex machine. In Fresenius machine, filtration fraction is not calculated. Then you can calculate. Obviously, it has to be continued 24 hours, more than that. So see in between, give some flushes of saline and see that the dialyzer doesn't get clotted. This is how it has to be.
So that was all about the acute hemodialysis prescription and the CRRT prescription. And then chronic hemodialysis prescription. With the for the chronic hemodialysis prescription, urea is used as a marker solute. Uremic toxicity is caused by both small and large molecular solutes. The small toxins are also of the greater importance. The urea is generally 60 daltons, which is slightly toxic, which reflects the smaller toxins also. Urea remole versus the serum level, both should be monitored during the chronic hemodialysis treatment. The inadequate if there's inadequate removal of the urea, then it indicates the inadequate dialysis. The serum urea level depends on the rate of removal and the rate of urea generation. And the urea generation is contributed by protein nitrogen appearance rate. The measures of the urea removal are urea reduction ratio, then single pool KT by V, then equilibrated KT by V, and weekly standard KT by V. Generally, the dose of dialysis in chronic for the chronic dialysis is thrice weekly dialysis. The National Cooperative Dialysis Study has shown that increased rate of treatment failure when the single pool KT by V is less than 0.8 compared with the single pool KT by V is more than 1. KIDCO recommends the minimum single pool KT by V of 1.2 during this thrice weekly dialysis. The European best practice guidelines recommends minimum equilibrated KT by V of 1.2 for the dialysis. The higher dose of the dialysis hasn't shown any improvement, any benefits. Like in the way of the patients did not live longer. They did not have not hospitalized less frequently, or there was no nutritional or other benefits. So all the recommendations are primarily opinion based. The effect of gender on the chronic hemodialysis dose is there's no firm data. The smaller patient should get relatively more dialysis when dose measured in terms of single pool KT by V. The malnourished patients should scale dialysis to the patient's optimum healthy weight. The residual renal urea clearance is entirely opinion based. The adequacy of the hemodialysis is according to the schedule 2 times per week. The KT is not recommended. 3 times per week, the KT we should target KT of 1.2, and if the 4 times per week, then we should target 0.8. The target single pool KT by V values should be about 15% higher than the minimal values which are shown above. The dialysis time, total weekly time can contribute to phosphorus and middle molecules. KIDCO guidelines shows minimum session length of 3 hours for the patient, which are dialyzed for the 3 times a week. The European best practice group recommends minimum 4 hours of the treatment in chronic hemodialysis patients. So writing the initial prescription, we need to calculate dialysis dose, which can be as K into T, in which K is the dialyzer clearance and T is the dialysis session length. Generally, K is that is dialyzer clearance is 200 to 600 ml per minute. The blood flow, which we can keep till the 400 ml per minute. Then dialyzed clearance, that is K, will be 230 plus minus 30 ml per minute. This all things can be calculated with the urea kinetics calculator. If we consider the dialyzer clearance as a 250 ml per minute, and the dialysis session is for the 4 hours, then KT will be 60 liter. That is, which will be the total of the blood cleared of urea, that is urea reduction ratio. This targeting KT on the basis of the patient size and determining KT by V, then prescribed KT by V of 1.4 to ensure that the delivered dose stays above 1.2. This desired single pool KT by V can be calculated in 3 steps. First, we have to estimate the patient's volume, urea distribution volume, which can be calculated as an anthropometric equation. There's a nomogram by Wiener's equation. We can assume this volume, urea distribution volume, as 40 liter. Then step 2 is compute the required K by T, KT. If the desired KT by V is 1.5 and estimated volume is 40 liter, then required KT we can calculate as a 60 liter. Step 3 will be the compute the required T or K, that is session time of the dialysis or dialysis clearance. The required KT is urea can be calculated with the urea modeling programs or internet based calculators. The required K, that is dialysis clearance, To calculate this, we can input a session length T and ask what kind of dialyzer blood flow rate or dialysis flow rate do I need to achieve the KT. So if we are deciding the KT by V of 1.5 and with the volume of 40 liter, then KT will be 60,000 ml. And if the desired session is about 4 hours, that is 240 minutes, then the required KT required K will be KT by T, that is around 250 ml per minute. The blood flow, blood flow, dialyzer flow, and coefficient of the dialyzer efficiency. This can be calculated with the nomogram. There are apps which dialyzer coefficient clearance value that will be required to achieve the clearance, dialysis clearance, which is 250 ml per minute at a blood flow rate of 400 ml per minute. So the prescription of the ultrafiltration rate in chronic hemodialysis depends on the patient factors like dry weight, rate of vascular refilling, then monitoring of the blood volume changes, and hydration status during the hemodialysis. The dry weight is defined as the lowest weight the patient can tolerate without the development of signs or symptoms of intravascular hypovolemia. So, as sir has described, we can prescribe the normal hemodialysis prescription in terms of frequency, duration, dialyzer, which dialyzer we are using, then blood flow, dialysate flow, then access, then any remote monitoring. If we are using any dialyzer, using the dialyzer. During this dialysis, patient monitoring is also important. We should, prior and during the dialysis, we should monitor the patient's weight, blood pressure, temperature, and the exercise. And lab tests like serum urea nitrogen, albumin, serum creatinine, serum total cholesterol, serum potassium, serum phosphorus, serum calcium, magnesium, alkaline phosphatase, bicarb, hemoglobin, aminotransferases, and parathyroid levels should be monitored during chronic hemodialysis patients in the chronic hemodialysis patient. Thank you. That's all.